How soon after stenting can you stop aspirin is a question that is being asked all across the world. For the longest time, DAPT for 12 months has been the recommendation from guidelines. But honestly, there's really nothing magical about the 12 months. This has been based on, from my understanding, the CURE trial from like over 20 years ago, as well as historically patients who had their antiplatelets stopped for about a year out while they had first generation type stents that landed them problems with late stent thrombosis. And that's what they kind of want to use the dual antiplatelet for a year to help address. Because when they actually stopped the dual antiplatelet therapy at about a year, that's when more late stent thrombosis events occurred. And also based on the estimates of how long or what the time requirement is for those stents to be properly healed over or endothelialized. Obviously, with dual antiplatelet therapies, is that bleeding risk is probably higher. And this has been shown in many studies, but we don't really know whether a shorter duration of this dual antiplatelet therapy would still be as effective for ischemic type outcomes and preventing stent thrombosis events from happening. Hi, if you're new here, I'm Herb, the heart pharmacist, where we go over everything cardiac medication related to help you choose and use wisely. Now, as you can probably hear, I've kind of lost my voice. This is not an uncommon thing, unfortunately. I seem to get laryngitis episodes like 3 times a year. So my apologies if I sound like a frog, but I wanted to get this video out because there has been a trial that was published recently that was requested by a PGY1 pharmacy resident named Rima Ahmad. Thank you very much for making this request. So Rima, if you are watching this, I know your journal club's coming up in about a week or so. I wanted to get this out so you can at least, go through some of it in a little bit more detail. I'm hoping that this will be helpful for you. If you're watching, grab a pen, some paper, and I'm going to be asking you to pause the video from time to time because I think it'll be helpful for you to stop and think about some of the things I'm going to ask and treat this as if it's like a live tutoring session. You will get much more out of this session by pausing and thinking about what I ask, and will know this study way better and remember the details better as well by doing it this way. Take my word for it, trust the process, and I recommend that if you find it helpful, that you continue trying to do and appraise your studies like this moving forward and build upon it over the many years to come in your career. So first up, there's a lot of information that can be gleaned just from the abstract alone. Here's a general approach that I like to take with new studies that come out. Number one, just look at what they're asking in terms of the question. What is their clinical question? The next thing I do is I peek down at the conclusion, and if the conclusion seems very plausible, very interesting, that could change practice, this is a study that I'm actually going to try to spend some time looking into. And this is where the whole learning for relevance is very important, because if you can find a way to apply it, you are going to remember, and it's going to stick in your head a lot better than if you just reading it for the sake of reading. So if you can pull up the full paper, just looking at the abstract, you'll see that this is a multi-center, open-label, randomized trial that looked at patients with heart attacks who ended up getting put on dual antiplatelet therapy for 1 month and also got what they call complete revascularization. And they were randomized to stopping the aspirin. So they're just left on that P2Y12 inhibitor. In this case, most of them got ticagrelor, followed by prasugrel, and then clopidogrel, or continued what the standard of therapy is, which is dual antiplatelet for the remainder of the 1 year. They wanted to know if there was a difference in outcomes at 1 year tested for non-inferiority for a net clinical benefit outcome measure. So here's a question you should ask yourself. What are the implications of an open label type of study, and what types of biases could be at play? I'm not saying that there are or there will be, but think about that. Hit the pause button. So the first type of bias that I think about is performance bias. And I've talked about this in a previous video, as both patients as well as the investigators know which treatment they're assigned. Could the overall result look better or worse for one group versus another? So for example, if you already know that you are on DAPT or DAPT, would you be more likely to report a bleeding event, even though it might not be as significant that requires hospitalization, but versus somebody who's just on one agent alone? Think about that. Detection bias is another one. If an outcome is subjective in nature, and this could be at play as well. So the good thing about this trial is that they have relatively objective types of outcomes. So they looked at all-cause mortality, they're either dead or alive. They looked at heart attack, stroke, stent thrombosis, kind of hard, but not as definitive, and major bleeding. And they have a pretty strict criteria for bleeding, so it's pretty objective. They didn't end up including endpoints like angina requiring hospitalizations, or things like ischemic-driven revascularization or target vessel revascularization. These are very sort of soft endpoints that sometimes trials will just put in for the purposes of increasing event rates. Another one that I try to think about is attrition bias. So say, for example, there's a less favorable treatment in the study. Could there be a higher dropout rate and create an imbalance between the groups in terms of the randomization because of that? And then that in turn can skew the results in a particular direction. So this is where I look at the rates of the loss to follow-up for the groups. You can find this in figure 1 usually. But as you can see in this trial, this is something that's relatively balanced, so it's probably not an issue for this particular study. Next, I look at the primary outcome. Think about each one of these components within that outcome. Think about it also as it relates to the type of analysis that was done for this study, which was a non-inferior type of analysis. Now, pause the video. So a non-inferiority test is designed to see that two different treatments are not different within a certain margin. Now, this can be a problem now when you have polarizing endpoints. So if you have, say, stent thrombosis and death, okay, which are like efficacy type outcomes, and then you also have safety ones put into it, like bleeding, you combine these together, how can you be certain that one isn't better or worse in various different ways? So for example, out of 10 people, you had 8 patients who had a stent thrombus event and died, and 2 events that were bleeding. Total event is 10. On the flip side, if, say, for the dual antiplatelet arm, you had 2 deaths, but you had like 8 bleeds, you would see that, hey, they still had 10 events. These two are not different, and therefore they are considered non-inferior. This is a question you should ask yourself. Do you value each of the components within the primary composite endpoint to be similar? If your answer is no, then you kind of know that, okay, well, this endpoint doesn't quite make sense for this type of analysis. If you look at the secondary endpoint, which includes the BARC or BARC type 2 bleeding in addition to 3 and 5, number 2 is significant bleeding that doesn't require any like interventions. They reach superiority in this abstract. If you're to be put on 2 antiplatelet agents versus 1, think about that. Are you likely to show a difference between the two? If we take a Bayesian view on this, our priors are actually quite optimistic that there's a difference. So I don't think that doing this superiority test really does anything, because we already know, and we don't really need a study to show this, is that dual antiplatelet therapy versus single antiplatelet therapy is associated with more bleeding. So in my opinion, it's kind of a stupid endpoint. I'm a little bit harsh in that way, but I want to actually take it one step further in that by them designing it in this way and reporting it this way, I think that you should be thinking about some level of possibly reporting bias for this study in favor of a shorter duration dual antiplatelet therapy, because they're really trying to showcase this bleeding thing as being a problem. It's just something to think about. Now, look at the conclusion again, with everything we talked about. We haven't actually gone to like the meat and potatoes. Look at how they reported the conclusion and the choice of words. This is something that you should always do. Does the wording seem objective for what they ultimately tried to study and how they concluded it? Or did they sort of try to stretch the conclusion? So in this case, amongst patients who are relatively low-risk patients who got stenting, complete revascularization, and had 1 month dual antiplatelet therapy, single antiplatelet with a P2Y12 inhibitor was not inferior to DAPT with respect to adverse CV events and was associated with less bleeding. Seems pretty objective for what we're looking at. So I don't think that there's a huge risk of sort of reporting bias in this way. Now, here is where if you don't know the topic very well, sometimes it might be helpful to look at the introduction sort of paragraphs before they get to the methods. But very often I just jump straight to the methods because I want to see sort of the scope of which they tried to study this population and the types of resources that were utilized, whether they had independent safety data monitoring boards or separate clinical events adjudication committees. And if they did not, would there be any sort of financial incentive for the sponsors to make the study look better in some way, and whether there are any significant risks of biases through that. And then what I do is then I look down to see who they actually included in the study. Investigators can have a fairly hard time trying to enroll patients because of the fairly strict inclusion criteria that trials generally have. And even after they meet all the requirements and the criteria, you still have to get consent from people, which can be challenging sometimes. Now, say you know the overall results of the study that these two groups or these two treatment pathways are non-inferior. Think about in real world practice, are the patients that you see, are they generally the types of patients that would have been included in this trial? So for example, these were patients who had STEMIs, who had NSTEMIs, they were about 50% each, but they had complete revascularization. So where I practice, they usually try to do complete revascularization if they came in, say, with a STEMI, but not necessarily the ones with an NSTEMI. And then also, when they do complete revascularization, they often will bring them back to the cath lab within about 45 days. That's about 6 weeks or so. In this trial, they actually brought them back in to do complete revascularization within 7 days, which is very fast. I'm not sure what the implications of this would be, the difference between doing it sooner versus later, but it's something to think about. They also used a very special biodegradable polymer stent called the Firehawk Liberty stent. This is not something that we generally use. But if you think about stents, first generation stents nobody really uses. Second generation stents are the ones that we commonly see. Every now and then, our interventionalists will use, say, a drug-eluting balloon. It's very rare that they will actually use a biodegradable polymer stent unless patients are enrolled in a trial, for example. But my understanding is that these biodegradable polymers, your endothelialization for your body to heal over that stent or that scaffolding really nicely takes place over the span of about 1 month to 3 months. So that's relatively quick compared to, say, a second generation stent where the time frame is more so around 3 to 6 months. So from my standpoint, these patients already have a leg up overall because of this special stent. Going back to that whole complete revascularization thing, that's also a fairly hot topic. I'm in the camp of not really revascularizing patients fully if the other lesions are not really causing any problems yet. But again, I'm not a doctor. I'm not an interventionalist. But from what I've read and what I know is that doing this doesn't really change any of the significant heart outcomes as per the complete trial. So the complete trial was a large study that looked at complete versus culprit-only revascularization in the STEMI population. The primary outcome was driven primarily by a reduction in ischemia-driven revascularization. And these are somewhat softer endpoints. So I know that there was a recent meta-analysis that was published in Lancet just a couple of weeks ago that pooled studies like that complete study, as well as the industry-sponsored FIRE trial and the full Revasc trial that was stopped prematurely because of ethical concerns of randomizing patients who had non-culprit lesions of like greater than 80% to incomplete revascularization. So the data that they had in that trial was, from my opinion, not the best anyway. What they ultimately conclude is that it does help for heart, like CV death type things, but that's kind of a little bit besides the point of this trial, but I just figured I'd mention it if you happen to be interested. So even though the study wasn't specifically testing the Firehawk stent, it was funded by Microport, which is the company who makes this Firehawk Liberty stent. They've chosen complete revascularization within 7 days from the index event. So, and it looks like that there could have been some subjectivity in deciding which lesions were stented. This is relatively reflective of real world practice, but I can't help but wonder if trying to publish a study like this and leading interventionalists to want to do more of these full revasc procedures and therefore using more of their product. Something to think about. Then I look at who they excluded from the trial. So patients who had any high-risk bleed features or had really bad kidney function. These are common reasons for why patients are not enrolled in trials like these. They were also excluded if they were patients who had high-risk ischemic events. So anybody who had undergone any complex PCI procedures, had any chronic total occlusions, so really, really calcified vessels that just developed over time. They also did not include anyone with left main stenting or left main disease or really long stents. So the patients that they selected in this trial were very, very low risk type of patients. Randomization seemed pretty standard. They used computer-generated sequence for their randomizations. For treatments, the P2Y12 inhibitor that they used were sort of up to the discretion of the investigators, and they tried to follow the guidelines. And the guidelines will usually tell you to use either ticagrelor or prasugrel over clopidogrel. Given that there's such few patients with clopidogrel, I don't know if I really feel super confident if you were to do this with clopidogrel compared to, say, prasugrel, for example. The thing about open label studies too is that when you know sort of what the treatments are, if you know that the more potent P2Y12 inhibitors are associated with a higher bleeding risk, sometimes these patients or people might tend to report them more often. If you happen to have higher bleeding overall, you would expect that the two groups would be relatively balanced, and that's if you are able to preserve randomization. So we talked a little bit about that net adverse clinical outcome, and so I'm not going to talk too much more about that, other than I don't think it really makes sense for this trial to use that type of outcome, especially if you're looking at a non-inferiority type of trial. Now, in terms of the statistical analysis, just full disclaimer, stats is not my forte, but there are some things that you should probably think about or ask yourself. So if they were assuming an event rate of 3.5 for the overall primary composite endpoint, but then in the study and then the results, they only got 2.2%, what does that really mean to you? Pause the video. So to me, when they did their power calculation for this trial, they used that 3.5% to get a sample size of 1,908 patients to be able to provide 80% power for this trial. Now, in your trial, you have less overall events. You're technically underpowered for this trial. If you're looking for differences with a smaller overall risk profile, like if your risk is like 2.2% and you're trying to suss out those differences, you actually need many more patients than, say, a baseline risk of 3.5%. So I just wanted to put that out there because overall, we see this a lot in a lot of cardiology trials. And the general theme is that, we have to end up pooling these trials eventually to get more power anyway. So they used a non-inferiority margin of 1.25 percentage point difference between the two as sort of the non-inferiority margin. So they're saying that if it goes above that 1.25% percentage points, then it would not meet non-inferiority. So for this trial, ultimately, when you look at the results, they had a percentage point difference of minus 0.09. And then the upper bound, if you look at the results, it goes up to 1.20. So it's still up within that 1.25 percentage points margin. So that's how they deemed it as being non-inferior. Now, we have to think about what this 1.25% really means. So if you look at a lot of the other trials, sometimes these trials will look at a non-inferiority margin, not in terms of percentage points, but in terms of the risk ratio. Like they might say a non-inferiority margin of like 1.3 or 1.5. So that's like they could be, 30% worse or 50% worse and still be within non-inferiority. This one seems very tight, 1.25. But if you think about it from like a relative risk standpoint, if your baseline risk is, say, 3.5% for your control arm, which is what they had planned, and if you can allow up to a 1.25%, that can go up to 4.75%. And if it was 4.7%, that would still be considered within that non-inferiority margin. Would you still think that is reasonable? Now, when you bring it back to what actually happened with this trial of their control arm having a risk of 2.2%, now you have allowed your events to be up to 3.45%. That is a pretty substantial increase. You're looking at 60 something percent increase in the risk. Think about it in context, because if you have baseline low rates, then it's a very high relative margin. Now, in this field of cardiology, where we're always looking at incremental benefits, the Plato trial, their ultimate primary outcome was 11.7% in the clopidogrel arm. So for Plato, they showed a close to 2%, like 1.9% absolute risk reduction with ticagrelor because they yielded a 9.8% So these patients at baseline had a higher event rate compared to this trial. And then in terms of relative terms, a 1.25% worsening would not be as bad compared to this trial. I hope that kind of makes sense. Not sure if I explained that very well. I'm just going to put this out there right now. I'm talking in a car, obviously. I'm doing this while my kids are in class, and this is the only free time I really have in the day. So I might actually cut out from this video, and depending on how things go. The next thing I want to talk to you about in this trial is that they used something called the intention to treat population. So the intention to treat is everybody in the study who had undergone the randomization process. So regardless of whether they took the drug or not, whether they've dropped out or lost the follow-up, they included everyone. First is, say, something called a per protocol analysis. This is where the people who actually took the treatments, those are the people who, followed the protocol and they didn't sort of deviate from the protocol. So these are the patients who actually stuck to the therapies. For a non-inferiority test, I want you to think about what the implications of it. Is it more conservative to do it one way, one analysis, or more conservative doing it the per protocol analysis way? Hit pause. So if you think that using the intention to treat population is not the best thing to do for a non-inferiority test, you are correct, because when you have a trial that's designed specifically to look for no difference, by nature of including all the people who were, say, didn't really take their meds, kind of were lost to follow-up, that just was like extra fluff in the study, you're more likely to drown out any possible signals for either your primary outcome or whatnot, just by virtue of having more data that's just there, versus a per protocol analysis where you've kind of weeded those people out, and then you're kind of amplifying the signals of the differences by using the per protocol analysis, making it harder for you to reach non-inferiority. That would be the right analysis to do for this trial. So I think they tried to explain it in their discussion section that they did this because they were concerned that doing the per protocol analysis would further have power issues. It's correct, but they were already underpowered to begin with. So that's something that you should really think about for any non-inferiority trial. Then I like to look at the baseline characteristics in table 1 to see whether so number 1, what did they include in this baseline table? And then 2, are they well balanced? So when you look at the table 1, a lot of these things make a lot of sense to include. Say, female gender. People who end up having stent thrombosis are more likely to be female. Obese patients, people who tend to smoke, people who have diabetes and are on insulin. These are everyone that they pretty much would identify for who could possibly be at higher risk for stent thrombosis complication. So I'm really happy to see that. Like they included CKD, patients who had prior infarcts, and for the most part, it was fairly balanced between the two groups. Now, if you go to the results section, I want you to look at each of the individual components, and you will see them in table 2. Now, obviously, the combined or the net clinical benefits outcome was relatively no different, but look at the things like the deaths rates, the stent thrombosis rates. So for stent thrombosis, there was only one event that happened, thank goodness, in the P2Y12 inhibitor monotherapy arm versus 0 for dual antiplatelets. But also look at the death. So there were 4 events that occurred in the monotherapy P2Y12 inhibitor arm and 2 events in the dual antiplatelet arm. So didn't reach any statistical significance. But however, given that this trial was overall an underpowered trial, I know that these patients were relatively low risk, but could these two be signals for an actual problem? I suspect that could be so. If you had more patients, even if they were low risk, it would not surprise me that these two, in terms of death and the stent thrombosis, could be amplified with more data. And we just don't have a means to really suss that out unless we ran a larger trial. Keep in mind that this was a trial of 2,000 something patients. The trials for a lot of the other bigger studies, Plato was 18,000, right? So this is really, really small. So I think that we probably should have more data that we should be thinking about and analyzing before we take away aspirin so early for everybody. Because to me, the risk of having a stent thrombosis event or death is much more important than, say, a BARC2 category type bleed. which is that secondary outcome that showed superiority. If you look at the BARC types 3 or 5 bleeding, there wasn't actually that much of a difference between the bleeding between the two. If you look at it, it was like 7 in each arm, right? So bleeding wasn't the primary driver of the primary endpoint, which is a good thing to note. But because of that, I think in some ways it kind of diluted out the sample as well. I got to go get my kids now, so we'll see you in my office. And I just teleported into my office. I've always wanted to do that. So overall, to summarize, I applaud the investigators for attempting to pare down the duration of dual antiplatelet therapy as early as 1 month. It was a fairly decent study with a relatively tighter non-inferiority margin compared to some of the other studies like the Ultimate DAPT study that I had covered previously, which you can find the video somewhere here, and Twilight, Neo Mindset, which came out not too long ago as well, where they used a non-inferiority margin of 2.5%. This one was basically half of that. But I think there's a lot to think about in terms of its external validity. So there's the issue of selecting out the patients who had already tolerated DAPT for a month. So you basically included a very low risk population, probably lower than the general public, because they had survived that 1 month. And that 1 month is usually when things like stent thrombosis and stuff usually occurs. I've mentioned this previously in the video where I addressed the Ultimate DAPT study as well. And you can find a summary of a lot of the other studies that looked into this shorter duration DAPT space. Then there's the issue of it being an open label study and subject to performance bias and maybe some other biases. Could they have added an aspirin placebo? And I know that it would have required a little bit more resources, but I do suspect that perhaps the BARC2 type bleeding, which ultimately showed in the main secondary endpoint to have been statistically significant, maybe it might not have been that bad. Then there's the issue of complete revascularization. For me, that isn't directly related to the whole dual antiplatelet therapy for 1 month versus a year thing. It suggests to me that the company is probably trying to find a strategy for people or interventionalists to use more of their product and increasing their sales. I'm not completely sold on the complete revascularization thing for everyone based off of what I know and what I've read. The majority of the patients did receive ticagrelor, in which it does apply to my patient population, but I think there's a lot of scrutiny about ticagrelor and the issues around data integrity that's still being investigated right now. There was a relatively small portion of patients who were actually receiving clopidogrel being represented in this study. And a lot of patients now, they seem to have atrial fibrillation at the time when they need PCI and stenting. So this study does not apply to these people. And we should not be extrapolating the results of this study to patients who need long-term anticoagulation. Even though it wasn't statistically significant for death and stent thrombosis, we know that this trial was not powered to detect those differences either. So, but numerically, we were already seeing some extra deaths and stent thrombosis events in the single P2Y12 inhibitor arm in this low-risk population. So I suspect that 1 month might still be a little premature, even for this type of stent, the Firehawk Liberty stent, which is not a standard drug-eluting metal type stent that we commonly see in our hospital. If you look at the supplemental appendix for this study too, is that the use of IVUS or OCT, which are techniques that they can use to enhance their effectiveness of a successful stent implantation, they were very few. They use these in maybe about no more than 2% of these cases overall. So I wonder if these techniques, if they were actually have been used more frequently in the study, we may not have actually seen some of these thrombosis or death events occur. I know this is a really long video, and if you happen to be one of the 1 to 5% of people who have watched or listened to this entire video up to this point, I'd really appreciate it if you could give this video a thumbs up if you found this video helpful in any way, or if there's a study you would like me to review in this sort of format, or perhaps there's anything I missed of this target first trial. Just let me know your thoughts. Again, thank you all for tuning in, and we'll see you in the next one. Say no to drugs.